Hello. Well, thank you so much to the Foundation for Angelman Syndrome Therapeutics for having us today. And we're going to be talking about an approach to sleep challenges in Angelman syndrome. My name is Dr. Jessica Duis. I'm the director of the Chromosome 15 Clinic at Children's Hospital Colorado. And I'm here with Terry Katz, who I'll let introduce herself.
Hi, it's an honor to be here. Thank you very much for allowing me to be part of this presentation. I'm a psychologist. I helped start a sleep clinic for individuals with neurodevelopmental challenges at Children's Hospital Colorado, and I still work in that clinic and done so now for many years. Also wrote a book on sleep and toolkits for families who need help with sleep in their child.
So, today we're going to talk about the scope of the issues with sleep in Angelman syndrome, behavioral approaches, medication management, and then we thought it'd be helpful to run through a few cases that we've run into working with individuals with Angelman to try to give you all a toolbox to try to work with some of the recommendations that we've made throughout the slides. So, sleep issues are very common in individuals with Angelman syndrome. The literature says 80% of kids with Angelman do have sleep concerns. And what are these sleep concerns? So, we definitely see that there's a decreased need for sleep. So, the duration of sleep is shorter. There's lots of nighttime awakenings with sleep. So, we have fragmented sleep. And one of the things that we see is that there's decreased REM sleep. So, our deepest sleep is much less in Angelman syndrome than we see in typically developing individuals. So, what's the impact of this on individuals with Angelman syndrome? So, we know that all aspects of Angelman could be more challenging or get worse if sleep is poor. So, particularly, we could have worsening seizure activity, learning and memory. So, our cognition and ability to learn during the day could be less. There could be poor attention. And there can be difficulty regulating behavior in general. So, more irritable, more anxious related to poor sleep. And then there can be some GI consequences of poor sleep, including reflux and constipation. So, this is actually data from a device that we use that we put underneath the mattress. It's called the Early Sense device. And one of the most exciting things about this data is that it is really reflective of what we know about Angelman syndrome and what we've been able to collect with sleep studies that are done in the hospital. So, we know that the time to fall asleep in Angelman is a lot longer. They spend a lot more time awake during the night. Their time asleep is much less, and their time in bed is much less. Overall, when we think about sleep, we look at sleep efficiency, and a normal sleep efficiency is going to be 80% or above. And you can see that the kids with Angelman in this study had a sleep efficiency of about 70%. This is also from that same device. So, this is what we call a hypnogram. And in this picture, you can see that during different stages of sleep, there are these what look like lines. And you can see that each of these lines represents a nighttime awakening. So within each of these 2 hour periods, you can see that there are many times that individuals with Angelman will awaken during the night. And this lower picture is actually from a study of individuals with Angelman who had overnight sleep studies. And one of the exciting things is that this device actually looks like it's reflective of what we know about Angelman syndrome. So, how do we approach this? Well, first of all, we need to identify that there is a concern about sleep. And so, a lot of times, we'll actually talk to the families about what the impact is of poor sleep on the family unit, including the individual with AS and the family or caretaker. In addition, we'll think about whether a sleep study would be helpful. Now, a lot of times, sleep studies are not helpful in individuals with Angelman because they get very anxious, as you all probably know, in unfamiliar environments. And what we've seen is that we really don't get much sleep that's reflective of what things look like at home. The few times that we will try to get a sleep study would be if there's concerns that there's events where the child stops breathing. So, sleep related breathing problems that could include obstructive sleep apnea or a problem with the brain's regulation of breathing during sleep. We also worry if there's some unusual behavior during sleep. This could be indicative of seizures during sleep, and we definitely want to make sure that we're appropriately treating the underlying problem. So, we may recommend doing a sleep study with an EEG overnight. Other ways that we can identify problems with sleep are actually just through a sleep diary where a parent will take notes on how sleep is going overnight, or actigraphy, which is a wearable device that will look at how much movement there is during sleep, to try to give us a sense of how often that individual's awake at night. And then there is a growing use of these home devices, similar to what I described that we used in our study, like the Early Sense device. Some of those might be connected to iPhones, like a Bedtime device. Um, and then the other thing we think about is some of the other medical things that can go along with restless sleep. There was recently an article that came out looking at individuals with neurodevelopmental disabilities, recognizing that restless sleep could be related to low iron stores or ferritin. And so that's something that we think about. We also think about, could the child be having pain? Could there be a dental pain or pain somewhere else, maybe in the legs, depending on how the child's doing walking? Allergies can be a problem. There can be postnasal drip that can actually contribute to waking up at night, and then itching as well. So, if the child has eczema, this could be something that we're thinking about. So, what are our steps to management of these concerns? So, we would start with managing some of these contributing medical problems. So, reflux is another big one where you can have the child awakening from stuff coming up, and so we try to recognize that problem and treat it effectively, often with medications. We'll think about mental health, and anxiety is definitely a large factor in Angelman syndrome. And then, as I mentioned, those low iron stores or anemia could be contributing to poor sleep. We'll also think about treating some of those sleep disordered breathing that we talked about. So, if there's obstruction, or if, for example, if the tonsils are big, we might recommend seeing the ear, nose, and throat doctor to look at tonsils and adenoids, or we might recommend trying different um, respiratory machines to keep the airway open, which certainly can be challenging in this population, but we've had to use before. Um, we often make sure that the bed is safe and comforting to the child, and a lot of times we're recommending safe sleep beds depending on the age of the child and how the family feels like sleep is going. We're going to talk a lot, or Dr. Katz is going to talk a lot about promoting sleep hygiene, and this is really the most important thing. That's why I've highlighted it here. If you can't get the environment right and the sleep hygiene, including the routine before bedtime, right, a lot of times this fifth thing, medication management, is not going to be effective. And so we really promote working on behavioral management of sleep as a first step.
Okay, so thank you, Dr. Duis. I'm going to talk about behavioral strategies, as Dr. Duis mentioned. And I think it's important to go over a few ideas about sleep because understanding those will make the behavioral strategies make more sense in terms of why we're doing those and why we think those might be helpful. So one thing to know about sleep is that we go through different stages when we sleep. So it's not just we fall asleep and that's it, and it's all the same all night. In fact, we cycle through phases. About every 90 minutes we go from a very light stage of sleep to a heavier stage, and then we go through REM or dream state, and then we go back to this lighter stage. We tend to spend a little more time in the heavier stages of sleep at the beginning of the night and more time in dream sleep toward the end of the night. But we go through these 90-minute cycles, and later as we start talking about behavioral strategies, it'll make sense why we're thinking about that and why that's important. Next slide, please. Another piece that's important to think about in terms of sleep is what kind of helps regulate our sleep. When are we sleepy? Why do we sleep at night? Why are we up during the day? So a big piece of that is what's called circadian rhythms. And circadian rhythms occur about every 24 hours, but not exactly so. And these includes a lot of different patterns, including sleep and waking, but also when we're active, when we're hungry, when we eat, differences in our body temperature, and when we release various hormones. Next slide, please. When we're talking about sleep and thinking about circadian rhythms around that, one of the things that's important to know about that is that as we go through our circadian rhythms in a 24-hour period, we have times when we're extra sleepy and we have times when we're extra alert. And one of the times when we tend to be more alert is about an hour or so before our naturally occurring bedtime. Again, the importance of that, we'll talk about that a little later when we think about, well, when should bedtime be? When should we, especially when we're in charge of putting our children to sleep, when should that be? When should we decide bedtime is? Okay, next slide, please. I mentioned that circadian rhythms aren't quite 24 hours, but we're on a 24-hour cycle. So there are things that help keep us in alignment with this 24-hour cycle, and they're called Zeitgebers or timekeepers. Zeitgebers is German. And there's a number of things that help kind of keep us in line. One of the most important is social demands, social expectations. We see what everyone else is doing in our community in terms of when they're up, when they go to sleep, and understanding that in a household, seeing that everybody's kind of getting ready for bed, putting on pajamas, doing the kinds of things that you do when it's time for sleep, helps us realize, oh, we should go to sleep too. Time cues are important as well. Just the time of day, things that we do at certain times during the day will help cue us to when it's time for sleep or time to wake up. And then light is a very important piece of what regulates our sleep. We're more alert when there's lots of light, and we're sleepier when there's lower light. And part of the reason for that, let's see in the next slide, please, which is our melatonin production. So within our brain, in the pineal gland, we produce something called melatonin, and we produce much more of it when it's dark. And when it's very bright out, our melatonin levels go down. So when we're thinking about how to kind of prime our bodies for being alert during the day and being sleepy at night, we're going to want to think a lot about light. And we will talk about that as we think about sleep habits as well. Next slide, please. So again, here's our slide with circadian rhythms, where we see times when we're more awake and when we're sleepier. And then the other sleep drive that we want to think about is called the homeostatic drive. And that one is pretty straightforward. There aren't ups and downs, as you can see. And it's pretty much a nice analogy for that is the fuel in your car when you're driving. If you just keep driving, you use more and more fuel. If you keep going without refueling, you're going to run out of gas, and that's it. So that's kind of how the homeostatic sleep drive is. You go through the day, the longer you're up, the less, your sleep drive increases the longer you go, because you have less of that wakefulness and more of the sleepiness in you. And part of what gets over this hump is the circadian rhythms, where we get this sort of burst of alertness, or this second wind, as it were, toward bedtime. Okay, next slide, please. All right, so people always want to know, well, how much sleep should my child get? What's the right amount? Is my child getting enough? Is it too little? Is it too much? Sometimes we see that as well. I will tell you that when I work with families in our clinic, we're really focusing on the quality of sleep. How long does it take to fall asleep? Are you able to just go to bed without a lot of struggle or anxiety? Can you sleep through the night? If we get those things down, then we can kind of think about, is there a way to increase the actual amount of sleep or not? But I know everybody kind of wants to know, what's the range? Where's my child? So I always like to show this for families. This slide, this data is from the National Sleep Foundation. And one of the reasons I like this one in particular is that you can see there's a recommended amount, and then there's a range around that in terms of what might be appropriate, right? Because it's different for different people. Each individual has their own specific sleep needs. And then there's always this, the area around like, really, no, that's way less than we even think for any individual. And that may be a sign that that person needs to try to sleep more. But even then, there are things called short sleepers and long sleepers. Some people just need less sleep. Others need more. One of the ways we tell that is how you're functioning during the day. So, we talked about how poor sleep can impact daytime functioning. So this is one of the things, and parents, I think, know very well, and their child's grumpier, they're having more trouble focusing. It may be because they're not getting enough sleep. And that's when we might want to look at the quality of sleep as well as how long they're sleeping each night. Okay, next slide, please. All right, so we've kind of been talking about, there's biological factors that affect our sleep, there's medical factors, and then there's the behavioral piece. And that's really what I'm going to focus on over this next little bit of time. So let's go to our next slide. So there's a number of strategies we can look at, different factors, different aspects of our day that affects how we sleep at night. And we're going to go through each of these, but I'll just highlight them right now and then we'll unpack each of them a bit. And one is what happens during the day that absolutely affects sleep, what we're doing in the evening, kind of that time between dinner and bedtime, what our sleep environment looks like. Where are we sleeping? How much is that conducive to falling asleep and staying asleep during the night? Little bedtime routines that help us realize we're going to make this transition from being awake to going to sleep. Using visual supports can often be very helpful. And then this timing of bedtime, which we've discussed a little bit, but we'll talk about more. Next slide, please. So daytime factors. Some of the factors that we know helps promote sleep at night is exercise. Ideally, in a perfect world, we would exercise early in the morning, probably at the same time every day. That's a lot easier said than done. And it's as good a time as any for me to mention that I know a lot of what I'm going to talk about now is easier said than necessarily just putting right into place. There's lots of little strategies and techniques to do this, but the more of these things we can do, the better in terms of sleep. And sometimes it's about picking one or two to start with and then getting those on, in control and then moving on from there. But exercise absolutely does help. We don't want to exercise too close to bedtime. And people often think, oh, if I get really busy or I have my child run around a lot right before bed, they'll get out all that extra energy and they'll be ready for sleep. But often it's really the other way around, that if you exercise or you're active right before bed, you become aroused, and it takes time for that arousal level to get down low enough where you're ready for sleep. So earlier in the day is better. Light, which we're going to talk about a lot, but light during the day helps us stay alert. It kind of keeps us well regulated, right? We want a lot of light during the day. We want to get those melatonin levels down. We want to be alert and active. So then at night, as the lights start to go down, our melatonin levels will go up and we'll be more primed for that to happen. So we want to try to have nice light exposure. Again, first thing in the morning is a great time to start so that we've got this initial like, yep, it's time to be up and alert and not sleepy. Caffeine is also important to think about. I think a lot of people know that caffeine makes it hard to sleep, but caffeine can be in things that we don't always recognize. So sometimes drinks like Mountain Dew looks like this clear pop. So how could it have caffeine? It has a tremendous amount of caffeine. So you want to think about that. And think about, even when you have this. So there have been studies that show that the half-life of caffeine, or how long it stays in our system, is about 6 hours. So that's in adults. Understandably, they have not done a study on children to see how long it takes caffeine to stay in a child's system. But you figure if it's at least 6 hours with an adult, my thought is always like, might be even longer, right, for a littler person. So you want to be careful about caffeine. Probably the best idea is to just not have it. I see lots of children who have gotten used to drinking Coke. Maybe they have a sip from their parents, or tea, or even coffee. So we think about ways to gradually change that. If it's hard to change those habits for a child, or maybe we can substitute with a decaffeinated soda, or gradually dilute that soda so it's half and half for a while, and then it's 3/4 and a quarter. But we try to kind of be done with caffeine. Also, chocolate doesn't actually have caffeine, but it has something that's a lot like caffeine. So chocolate right before bed or late in the afternoon might also interfere with sleep. So something to think about. Nap time's a little bit tricky, especially for children who are having, struggling during the night to sleep. Sometimes it feels like they just need a nap, and of course, littler ones do. But naps too late in the afternoon interfere with that homeostatic sleep drive we were just talking about. So driving our car, we're running out of gas, which is what we want our children to do as it gets later the day. But if they take a nap, they have refueled. And sometimes even a short little nap is enough to refuel someone. So we just have to kind of think about naps carefully. A good rule of thumb is that you should be up, or your child should be up by 4 o'clock. So that gives them time to kind of recover and then fall back asleep when they need to. But I've certainly worked with families where we've just very carefully taken data and looked at how long a nap, exactly when. Because I certainly recognize that we say, you know, be careful about naps, and you have a child who's really grumpy and just really needs a nap. Again, easy for me to say, oh, no naps after 4, and you're sitting here listening, saying, like, you know, you try it. That is like really hard to get through the rest of the day. So sometimes it's some trial and error and figuring it out. But understanding that idea, I think, is important, at least knowing, well, if it's going to be a late nap, it's going to be a later bedtime. And then bedroom use is on here because for many individuals, it's helpful to establish that your bed and your bedroom is for sleep. That's what it's for. It's not for playing, it's not for watching TV. Again, it's for sleep related activities. So we always have to kind of think about that with each family and do what makes sense. Some families, bedroom needs to be where a child plays. There isn't another room for them to play. So then we think about maybe we can kind of tape off a certain part of the room that's just for play, or put down a mat so the child knows this is where I play, but my bed is where I sleep, and kind of think through that. If you're using a safe sleep bed, having it zipped up during the day, so that's not where we're going. We're somewhere else in the bedroom helps, so that we just build this association. Now it's nighttime. We're going into our bed. What do we do there? We sleep. We don't do these other things that we do during the day, and trying to help get that idea across to children. So we think about bedroom use if we can. Okay, next slide, please. I mentioned evening habits. So this is that time, dinner's over, it's not quite bedtime yet. What are we going to do during that time? So as we're moving towards sleep, we want to think about having less stimulating activities, more calming activities. So we've moved from the more active, we're out, we're doing all these fun things, to like, now it's time for more calming activities. We're going to start getting those lights down low, really about an hour or so before bedtime. We want to get the lights as low as we can. So that usually means no more electronics, no more TV if we can. Again, I say that, and I work with many families where that's the idea. We know that's what's going to work, but in the practical day to day of how we're going to accomplish this, it's going to have to be done a little bit at a time, or maybe we're going to have to make some compromises around it. Maybe there's TV is on, but it's on low. If you're using a TV, and so many of them are now, as a smart screen, or you're using any electronics, putting it into night shift or night mode helps a lot, so that we're decreasing blue light. So when we're talking about less light, overhead lights, white lights, contains the full spectrum of light, including blue light. And blue light is actually the worst light. It interferes with sleep the most. And all our devices are blue light. So we want to think about ways to mask that. Again, it's really nice. The companies that make these devices have figured that out. And there's, again, night mode, night shift, different ways you can limit the blue light. Also, like for children who have the lights on, if you can get them down low, or even if you're using a night light, to use a red night light, or even red lights. We're getting close to Christmas. I just worked with a family today that said, yep, tomorrow we're not trick-or-treating, so instead we're decorating our house for Christmas. And it's like, let's use those red lights instead of white lights. Those could help. And just thinking about routines that are more calming and restful toward the end of the evening. So we're getting those the arousal levels down. We're moving toward this. What are we going to do next? Well, actually, we're going to move towards sleep. Okay, next slide, please. When we think about, we're moving toward bed and sleep, where is that going to happen? Where is your child going to sleep? So we've got safe sleep beds written down, because I think that's a very helpful strategy. And I know for many of you, it's where your child sleeps, and that is great. I think a nice, secure place is often very comforting for children. We want to think through what the temperature of the room, if possible. Slightly cooler temperatures promote sleep, but it has to be a comfortable temperature, of course. And then thinking about textures, comfortable sheets. I have a little sleeping bag there, because I've found that for many children I work with, especially if there's some restless sleep involved, having something like a child size or regular size cotton sleeping bag, not nylon because those tend to be too slippy, but a cotton sleeping bag, you kind of can get in and get a little extra input and support. You can even stuff it a little bit with some pillows to put in some support. Can be helpful that way. Some I have sound on there because sometimes we talk about sound machines, and those could be helpful. And then again, of course, we want the lights down as low as possible. For once we're in bed, we want it off. A night light is fine. Again, a red night light would probably be best if we do that, but as little light as possible. And to think about any devices with blue light that might be on, and to address that if need be. I think the other piece that's important to know about sleep environment, we're going to talk about this a lot, is where you fall asleep at night needs to be where you sleep all night. Okay, because what we want to do when someone is falling asleep at the beginning of the night, whatever they're using to fall asleep and wherever they're falling asleep, we want that to stay consistent all night. Otherwise, they're more likely to wake up during those 90-minute cycles that we were talking about. So this goes back to why we wanted to discuss that. So we want to think about, where is your child falling asleep? And if you're not using a safe sleep bed yet, or if your child's in, sleeping with you or sleeping on the couch or sleeping in their bed with you. We want to make sure this all stays consistent because if there's a change, that child's much more likely to wake up. So I'll see this a lot. Children, it's been hard for them to fall asleep. So again, another important thing to remember. Uh, I worked with many families who've done whatever they could to get their child to sleep, and there is no judgment at all about how you've done that. You want your child to sleep. You're trying to figure it out. It is not easy. But knowing some of the things about what's going to help promote sleep and help them maintain sleep is important. So one thing, we'll often see is a child who, for whatever reason, it's easier for them. They fall asleep on the couch. They want to cuddle with their parents. Yeah, with a guy not too long ago, he liked sleeping in a recliner. So the issue is then parents, understandably say, okay, now you're asleep. Now I'm going to move you to your bed because that's where I want you to sleep for the night. But just that change alone can often result in a child waking up during one of those 90-minute cycles. So thinking through where you want your child to sleep for the entire night is important so that we don't have that change. Okay, next slide, please. So bedtime routines, I think, are very, very important and helpful. This is that idea again. We talked about, evening. We've kind of slowed things down a bit. Things are mellow, and now it's time. It's time to think about getting into bed. But before we do that, we want to have a set of little activities that are very much geared toward the next thing we're going to do is go to bed. So what we're going to do is come up with a little list of those that are consistent, and we can do them the same way every night. They're calming and they're easy. So when I work on coming up with bedtime routines for families, we kind of think through what can those be, what will work well. Some common bedtime activities aren't always the best thing to do right before bed because they're upsetting to a child, and again, very arousing. So an example that comes up a lot is teeth brushing. It's often very challenging for children. For teeth brushing, they cry, they don't like it. So that's probably not a great thing to do right before bed, right? So maybe we'll do toothbrushing right after dinner, have time to recover from that, and then we can have other things in our bedtime routine, which maybe is putting on pajamas, listening to some music, hearing a story, some nice calming sensory strategies, things that are going to be calming and relaxing and easy and not exciting. So bath time is another good example of that. It's often very relaxing and a nice bedtime routine, but for some children, it's really exciting to be in their bath. They get so aroused. And so that's, again, maybe not such a great thing to do right before bed. So you want to think carefully about what those activities are. You come up with, 3, 4, maybe 5 or so at the most, just that are calming and easy and that you can do in the same order each night. And if as much as possible, we want those to not have an electronic component to it, right? Because of the blue light and the idea that it's sometimes hard to let go of those once it's time to go to sleep. And then we're going to use a visual schedule so that everyone kind of knows what are those steps, both adults and children, so we can get used to those routines. And going through a bedtime routine in the same order and then going into bed really does help promote sleep. It also makes bedtime just more relaxing and more pleasant once you get to that point. Okay, next slide. So this is just an example, a couple of examples of visual schedules. One, children who like to be able to see, read or see the words for their schedule, and then you can always use icons or photos. And I just learned about a nice app online where you can actually insert photos of your child for their sleep routine, which might be really nice as well. These are just a couple of examples of how to do that. And you can put each card on a piece of Velcro so that you can Velcro them off as you've gone through each step, or put a check mark by them. Next slide. Not all children, it doesn't work always to use icons or photos. So sometimes we use objects. So this is an example of someone's bedtime routine with objects, and these are Velcroed on. So we know at first we go to the bathroom, so we've got a roll of toilet paper to represent bathroom time. Then it's about washing up, so we've got a little bar of soap, and taking a bath, brushing hair, putting on lotion, and listening to music. And so take off each of those as you go through each step of your routine. And for individuals where objects aren't as meaningful either, we'll just put in some consistent cues in the environment that really help mark this difference between we've been up, we've been awake, now we're going to do these little things, these little activities, and then we're going to go to bed. So we're marking the transition, because transitions are often hard. And really the hardest transition, I think, for most of us each day is from being awake to going to sleep. So we want to do as much as we can to help. Some of those cues in the environment could be things like having a special scent for lotion that's just for bedtime, um, special music that's just for bedtime, things like that. Okay, next slide. So we talked about the timing of bedtime when we were talking about this bump in circadian rhythms where we're more alert. And you can see sleep researchers call it the forbidden zone. So that's a pretty strong way of saying, don't put your child to bed too early because they will not fall asleep. And I would think that probably many of you have experienced this if you've ever decided, well, I have to get up really early the next morning. So I'm going to go to bed extra early. So that'll be perfect, right? I'll get that extra sleep. I'll be ready to go. And what happens? You don't fall asleep. And in fact, oftentimes you're up even later because you've been rolling around in bed and you can't sleep and you're getting more anxious. So we don't want that to happen to our children every night, right? Where they can't go to sleep yet. It's too early. So we want to think through, when do they tend to fall asleep? Sometimes what we'll do is we have that bedtime routine put in place later when your child is actually falling asleep. Sometimes their regular time to sleep is later than you want. But if you establish these good routines around the time when they are now falling asleep, and then you establish these good habits, you can move the time back. And I usually do that in like 15-minute increments. So let's say, you're been putting your child to bed at 8 because that's when bedtime should be, but your child actually falls asleep at 10. You might do your whole little bedtime routine around 10, start establishing good sleep habits, and then once that's happened, you can try 9:45, then 9:30, etc., until you back it up to where it's a good time, but not into that forbidden zone. Okay, next slide, please. Night wakings are, I know, an important issue and a common one. Again, behaviorally, what we really want to do is make sure that we've established a way for your child to fall asleep that they can maintain throughout the night on their own, right? So if they fall asleep watching TV, they're going to need to watch TV sometime during those cycles where they wake up. So, you have to keep the TV on all night, or the TV has to get turned off before they fall asleep. If they cuddle with you, same idea. They're using you. You're kind of their pillow for falling asleep at night. They're going to need you. So, you have to kind of think through, how's that going to work? Do you want the TV on all night? Do you want to stay with your child all night? Do you want to have to come back in each time they wake up? Or do you want them to learn to fall asleep independently? And you have to kind of think through that, decide what works for your family. But one strategy that often works to help children learn to fall asleep more independently is to let them do whatever it is they've been doing, cuddling with you, watching TV, but then stop it when they're really sleepy, when they're drowsy, but they're not yet asleep yet. And then they have just like maybe a minute or less to kind of settle and fall asleep on their own. And then once that's successful, you could gradually increase the time that you're asking them to do this on their own without those other aids in place. So thinking through what those are for your child, what can be maintained. A noise machine can stay on all night, for example. Sometimes calming music works. So you have to just kind of think through that. But we want that consistency throughout the night. And then next slide, please. If your child does wake up, you do want to respond pretty quickly so they don't get too upset, but you want to keep those interactions brief and boring. Sometimes visual aids help. You can have, there's okay to wake lights and little signs you could put up, like you have to stay in your bed now. Sometimes, if you're coming up with a new strategy around this, it can get worse before it gets better. And sometimes using rewards to help children stay in their bed makes sense. I always like to make sure as we're working on night wakings that we've really taken care of that beginning of the night part and we know what we're dealing with, and making the decisions about that, right? So that we know, well, yeah, he's going to wake up because I moved him from the couch into his bed, or yeah, he's going to wake up because we were cuddling and then I left for the night. So, how are we going to address this in the middle of the night? Okay, next slide, please. Another strategy that sometimes can help is called a bedtime path. And that's just a little card you give your child at the beginning of the night, and it gives them a chance to check in with you. So, children who really need that check in, they know they've got this little path. They can call for their parents if they could see their parents. But if they don't need to use it and they can hang on to it, in the morning they can trade that in for a prize. And that sometimes helps children develop that kind of that confidence to stay in bed, especially if you've addressed those how they fall asleep at the beginning of the night. Okay, next slide, please. Early morning wakings are a little bit different from middle of the night wakings, because early morning wakings are you're just up, it's 4 in the morning, but you're ready to go. So it's a little bit different that way. Sometimes that happens when we're dealing with depression or anxiety. So we want to consider that. But sometimes it's just a matter of, your child's going to just sleep for this many hours. You get 8 hours and you just have to figure out when you want those. So maybe you're going to delay bedtime so they could stay asleep a little later. Or you kind of make the decision, when do you want that extra time? Do you want them to go to bed early and then be up early? And we can also sometimes work with children to learn to stay in bed and play quietly, and especially with those safe sleep beds, that can often work. And again, it sometimes helps to reward children for that. And of course, anytime we're working with a child who's waking up during the night, we want to make sure that everything's child-proofed and we've addressed any safety around them getting up at night. Okay. So these are just some resources for you. This is a book I wrote. Another book by Mark Duran that's excellent. And there's a nice toolkit from Autism Speaks that's available that I also helped work on. So it's similar to the book I wrote with some strategies in it that could be helpful. Next slide. And we talked about sometimes needing an EEG, and I helped work on a toolkit for both providers and parents that help your child kind of get through having an EEG, some tricks to help with that. Okay.
So, the last thing we think about after we've implemented behavioral changes a lot of times is medication approaches. And this is the approach that I tend to use in clinic. I always think about benzodiazepines first in Angelman syndrome, and that's because we know that the GABA receptor, so the inhibitory neurotransmitter in the brain, is impacted by Angelman syndrome, and benzodiazepines specifically target those receptors. And so I have found sometimes just starting a really low dose of clonazepam at bedtime can be very helpful with Angelman, even from a very young age, if we're having a lot of sleep issues, even in that first year of life. Melatonin is something that we'll often recommend, and Dr. Katz addressed melatonin is a hormone that is released naturally in our brain to signal it's time to get sleepy and go to sleep. Melatonin can be really helpful in terms of falling asleep. There is also long-acting versions if your child can take a pill, but we haven't had as much success with keeping kids asleep and with those nighttime wakenings that are an issue with Angelman syndrome. My next go-to tends to be clonidine. which targets the alpha receptors. And clonidine can be really successful in part because anxiety can play a large role in children falling asleep with Angelman syndrome. And so we can sometimes use a low dose of clonidine to help with sleep. We also will think about SSRIs, or selective serotonin reuptake inhibitors. And there's an atypical SSRI, mirtazapine, that we actually recently published a case series on that showed that that is actually quite beneficial in many kids with Angelman for sleep. Um, a lot of families have been able to actually not use that every day, but every other day at a really low dose. We don't go more than half a tablet to start, especially because we've had kids with Angelman go on it and sleep for 2 days because they haven't slept in a long time, and then they get that medication and actually helps them sleep. So we recommend seeing how your child does on it, and then maybe dosing it kind of atypically from what you would think, either every day or every couple days or only when you need it. And it seems to be really helping some families. Trazodone is another one. That is in this same class that can be really helpful. And these medications also target anxiety, which may be why they're so successful. The other and kind of the last resort, although I do have a lot of kids on it, is Seroquel. So Seroquel is actually an antipsychotic medication, but we tend to use it at lower doses in Angelman syndrome for sleep, and it tends to be pretty helpful. So I thought that it would be helpful to go through some common scenarios that we see in clinic. So we'll start with this case. It's a 7-year-old girl with Angelman who has previously always fallen asleep with dad in bed with her in her bedroom. But we've recently seen them in clinic and recommended trying to transition actually dad out of her bed. And we have ordered a safe sleep bed for them, and parents are now trying to get her to sleep in that bed, but she's still having a lot of nighttime wakenings around 1 to 3 in the morning and having trouble falling back asleep, which is actually leading to her just going ahead and getting back in parents' bed. So I thought I'd have Dr. Katz start with behaviorally how to approach this, and then we can talk about some medications as well.
Sure. So this is a very common issue that comes up all the time. And again, I think this idea that, no judgment, this family did what they needed to do to help their child fall asleep. And now they're trying to come up with a new plan around that. And it can be tough, but it can absolutely be done. And I think one of the things we'd want to, talk about and think about is, again, how is she falling asleep at the beginning of the night? We want to make sure that she's falling asleep independently, because if she's still cuddling with her dad, she's going to need that as she cycles through these different phases. So that's an easy thing to say, takes some time to accomplish. One of the ways that this really could work, though, is to start to gradually move her dad out of bed. They could start with a cuddle, and it could be part of her bedtime routine, which might be a really lovely, nice part of the routine. And then make sure that, as she's falling asleep, her dad moves away just enough so that she's got that minute or two to fall asleep. We could think about what else she can cuddle with. Sometimes it's a body pillow. Sometimes we put a worn t-shirt on the body pillow so it has a parent scent. If she's doing anything with like twirling hair or doing something like that, we could make sure that's on the body pillow too, or a stuffed animal that's got long fur on it. We would just kind of think through some of those pieces, make sure that we've got the way she's falling asleep at night can be maintained. And then, for her to be alone in her room might also be a bit challenging. So we might think about her dad gradually moving off the bed, and then just kind of being nearby, like on the floor, and then moving more and more slowly, gradually moving farther and farther away, from her bed until he's out of the room. So he doesn't have to leave all at once, so we get her used to being in her bed. They'd have that cuddle like she's used to. He would slowly move off the bed. He'd still be in her room. He'd slowly move farther and farther away from her bed and out of her room. And really, for some families, like the last step is some body part still in the room, like a leg or a hand. And then you're out. You're completely in the hallway and you're done. And it's been the slow, gradual process. Child's then learning gradually over time, I can do this. This is okay. It's not scary. I can handle this. And, with some patience, a plan like that would work. During those nighttime awakenings, again, if she's cuddling and falling asleep with her parent at the beginning of the night, it's hard to ask her to change that in the middle of the night. But as we move toward this more independent way of falling asleep, we can have her parents say, we love you, but it's time to go back to bed, and walk her back. So the idea of just being with her parents isn't part of what's waking her up, because that can also wake you up, right? If you get to do something really great when you're in this light phase of sleep and you realize that, you're going to be more likely to get yourself up and get to what you want to do during the night. So those would be some ways you could start. And again, it would be a matter of talking with parents and making sure they felt comfortable with that and felt supported in going through a plan like that.
And then this is a case sometimes we may augment with medications. First, we'd rule out any medical issues. Could there be reflux or any low iron that could be contributing to awakening at night? And then we would explore use of medications, particularly if we felt like anxiety around not having dad there was a big part of it that we couldn't overcome with behavioral interventions. Um, a lot of times kids are already on a benzodiazepine, particularly if they have seizures, so could be on fee already. In which case, we would typically not start with clonazepam for medication. We would try maybe long-acting melatonin or melatonin at first to help with falling asleep. But with nighttime awakening, we would pretty quickly consider moving to another medication like clonidine or an SSRI to see if we could help with sleep from a medication standpoint. And again, that's also a conversation with family about what they would feel most comfortable with and whether they want to go that route and try that or whether they just want to stick with behavioral interventions. The next case is a 3-year-old boy awakening multiple times at night. He's still in the crib, so he's able to stay in the crib, but he's pulling up to stand, cruising around the crib, and parents are worried about that transition out of the crib. But he's starting to climb out, so they're recognizing, we really have to make some transition from a safety standpoint. They do have a monitor, and they're noticing he's very restless, up a lot of the night. And they're worried that this is starting to impact his behavior during the day. He's having more tantrums and getting a little bit more aggressive, pulling hair.
So again, we want to think about, how he's falling asleep at the beginning of the night, the term for that sleep onset associations. What is he using to fall asleep? Does he still have those during the night? So we'd want to just think through those things for him and make sure we're not missing something that he needs. This case reminds me of a family I've worked with just recently where this child was still using a pacifier. And so we just had to put pacifiers all over in the bed so that it was easy to find the lost pacifier and it wasn't just one. And that actually made a big difference. So we just want to make sure there isn't something simple that, the child's been using to fall asleep that isn't still there. Certainly, if we're starting to think about him needing to get, we don't want him climbing out of his crib, right? That wouldn't be safe. So this may also be a time to start thinking about moving to either a safe sleep bed or a toddler bed or something that is safe for this child, and then thinking through what will be comforting for him, with the restlessness, there's medical pieces to that. Again, I have found that things like a cotton sleeping bag, sometimes a weighted blanket, the research on that is mixed, but anecdotally, I have found something like that helps. And even sometimes a cotton sleeping bag, kind of stuffing in so there's lots of comfort, and then a weighted blanket over that. So as long as we're addressing any safety issues around all this extra bedding, that sometimes can do the trick in terms of some of that restlessness, if it's not about how they're falling asleep at the beginning of the night. And again, thinking through making sure that the lights are really down low. If a child is waking up during the night, that those lights stay low and they don't get turned on when they wake up, because that can make a big difference in terms of multiple night wakings as well. So those would be a few of the things we'd start to think about with this family.
Um, Definitely, and I second that it could be a really good time for a transition into a safe sleep bed because he's used to being in a crib, so something that's more comforting and enclosed could be a really successful transition when someone's transitioning from the crib. Um, Again, most of this will be behavioral interventions at this age. Occasionally I have put kids on clonazepam at this age if they're not on something like that, because that may be really helpful also towards comforting and going to bed. And like I said, may have some other benefits in Angelman syndrome. Um, and I just want to emphasize too that this is a dynamic process, so it's not, you come to clinic, you get some recommendations, and then you go home and it stops there. It's an ongoing conversation and often ongoing interventions. We hear what's working, we hear what's not working, and we modify our plan based on what's working for the family. I mean, we really value that relationship with family. The other thing I just wanted to mention that I've actually tried a lot recently is that they make some alarm clocks now that actually stay red all night and then turn green when it's okay to get out of bed. And I've had some success with Angelman using that alarm clock, to so that kids know that when they look over and it's the red, they can't get out of bed yet. And so that's just another type of visual cue to say, it's time for sleep now, it's time to stay in bed. And there could be, again, rewards or something associated with following through with that. So that has been a positive possibility as well.
I love that strategy. I've used it too. I think that's a great idea. And just to emphasize, a lot of this is trial and error. So you try something, you see if it works. If it doesn't, that's fine. You've gotten a lot of data, which means you can then keep moving toward an even better plan. Absolutely.
So, again, we're more than happy to answer additional questions or comments. Don't hesitate to email us, and we'll look forward to also our Q&A portion. Thank you so much for tuning in.
Thank you.